Hey everybody, welcome back to the ECG of the day. My name is Reed. Don't forget that you can download the PDF for this document right here. You can make your own notes. That link is down in the description, and don't forget to like and subscribe if you enjoy this content. So let's jump into this rhythm. This is a fun one. There's obvious findings, there's less obvious findings. Let's get into the nitty gritty. So first thing we're going to do, we're going to look at the forest. The trees of the forest are my QRS complexes I see down here in lead 2. Then I've got a narrow complex rhythm. It seems to be quite regular, and so it's kind of regular throughout the entire rhythm. You can see we've got a little bit of artifact here with some movement probably of one of the limbs, and so that's okay. And you can see there's even some motion artifact kind of throughout. It's going to make it a little bit trickier with motion artifact, but that's okay. We're going to power through and just kind of understand the patterns of this ECG using all the context clues. And the rate of this rhythm, if I find a QRS that lands on a solid line, maybe like this one right here, you can see the rate is going to be, if I count the number of small boxes, I like to do it this way. We'll do 5, 10, 15, 20, 25, 30, 34 small boxes. So we have 34 millimeters in between the two R to R's. And so the best way to do this really with a good calculation is you can do 1500 divided by 34 to get your rate, and 1500 divided by 34 is going to be 44 beats per minute. Okay, so we've got a bradycardia. Alrighty, so let's go ahead and start working on our differential diagnosis for a bradycardia. We can have AV blocks, you can have sinus bradycardia, you could have escape rhythms. And so we've got a narrow complex QRS, so we know that the likelihood of this QRS being generated by at least the AV junction or higher is pretty high. So we're going to have to kind of evaluate that. See, we'll start out with the atria. So we'll start with the atria. What we'll notice here is there are some P waves. I see a P wave here. That P wave, it does appear to be upright in lead 1. And if you look in AVF, you can see there's a P wave that's upright in AVF. So the P waves, when generated, do appear to be a sinus P wave. And so now we're going to look at our relationship of P waves to QRSs and see what our PR interval is, right? And this is really giving us our behavior of the AV node. And so the first thing we said is we've got a bradycardia, so let's kind of get an idea of what's going on. We don't have any group beating, so I don't think it's like a second degree type 1 or second degree AV block likely. It does seem like a regular bradycardia. It's in the range, I always think, when I see something that's in between 40 and 60 beats per minute, that is within the range of a junctional rhythm. I always think that in my mind. When it's regular, and it's between 40 and 60 beats per minute, that is the rate that typically the AV junction is able to create its own pacemaking. And so I always, in this patient, want to say, is this a complete heart block with a junctional escape rhythm? And so what I'm going to do is I'm going to take a look and see, well, what is the relationship of my P waves to my QRSs, right? There's a P wave here. Maybe that conducts to this QRS, right? I don't see a P wave that is in the same fashion in front of this QRS. Maybe this one does. Maybe that happens again over here, right? You can see that better on V6. Does that, right? These are all questions that I'm thinking about. And so one way that you can really evaluate, are these P waves conducting to the QRS, is, well, one, we have a very regular QRS rhythm, a very regular QRS that's occurring at 44 beats per minute. And so if there was some type of high-grade AV block, then what I should notice that there should be some type of relationship between the atrial rate and the ventricular rate. So I want to compare the P to P rate to the R to R rate, right? And that should help me determine, if every 2 P waves conducts to a QRS, well, then my P to P should be twice that of my R to R. And if vice versa, right? And so in terms of how fast they're going. And so what I'll do is we've already calculated the interval from R to R is 34 millimeters. Let's calculate the interval of P to P. And so maybe I'll pick these P waves, maybe this one, I'll pick that one, and I'll pick this one. And so I'll count, and I say 5, 10, 15, 22 millimeters. And that doesn't look like 22 and 34. It's not like we have two 22 millimeter wide P2P intervals. That would be 44. That's not going to make sense. There's not 2 to 1. There's not 2 P waves for 1 QRS. The P to P interval seems to be kind of independent of my R to R, my QRS to QRS interval, right? And what you will notice here is that we've kind of got P waves marching through the rhythm in their own fashion, right? We've got a P wave that you can see buried in that ST segment right there. You can see a P wave right there. We've got another P wave here. We've got another P wave there. I would say the next P wave should be coming kind of right in the middle of that QRS complex, so it's likely a buried P wave somewhere in there. We've got another P wave here, and then same thing, we've kind of got this little P wave peeking its head out there, and then we've got a little bit of artifact, probably a P wave that's landing in there, and then you see another P wave. So P waves are marching through the rhythm at a rate that is not correlated in any fashion, in a 2 to 1, a 3 to 1, a 1 to 1 fashion, with a bradycardic rhythm that is also marching through the rate. So to me, that is the best data to say that there is dissociation between the atria and the ventricles. And so that tells me that there is a complete AV node block. So that is how I'm going to call this a third degree AV block, where no P waves are getting down to my QRS. So we have a third degree AV block with a junctional bradycardia, right? Because if the AV node is blocked, how are those QRSs going to be narrow? Well, they've got to be arising from somewhere here in the AV junction at 40 to 60 beats per minute, guys. So you need to have triggers in your mind. When you see a regular bradycardia at 44 beats per minute, find the objective data to support what is going on. Alrighty. Next thing we're going to do is we're going to look down at our QRS complex. We see our QRS is upright in lead 1. It is upright in AVF. So we have a nice normal QRS axis that's going down and to the left here in our axis little calculator. That's good. And we've got kind of a little bit of a poor R wave progression through the precordium. We'll kind of work through that here in a little bit. And our QT interval, we can measure that indirectly by, I like to just find two R's, and I find the midway point between them right here, and you can see that my T wave ends before that point. So I'd say my QT is good. All right, last thing but not least, this is why I never skip my approach, is we could have easily jumped to these ischemic changes, right? You've probably all noticed this already. I'll do this in green so that we get a little bit of contrast. If we look at our anatomical leads, our inferior leads, leads 2, 3, and AVF, have some pretty significant ST segment elevation. Here's AVF. So those are the inferior leads, leads 2, leads 3, leads AVF. So we have inferior ST elevation, right? And that's good in the sense that it's not good, but it's all through a certain anatomical distribution, right? It tells me that there is likely some infarction going on in that region. And we also have ST segment depression. We would call it reciprocal depression in my lateral leads, really the high lateral leads of AVL. And you can even see some depression here in lead 1. So we have reciprocal ST depression in my high lateral leads, leads 1 and AVL. And so we need to start understanding what is this syndrome that is going on. We've got a third degree AV block, and we have ST depression, or excuse me, ST elevation or inferior leads. Well, we know that the right coronary artery, or the RCA, it supplies oftentimes the inferior portion of the myocardium. So it often supplies the inferior and it supplies the SA and AV nodes. So this is really great to give us data that when we take this person to the cath lab and look through their vessels, when we have AV node block and inferior ST segment elevation, that is really telling me that the RCA territory is being severely impacted to the point where the AV node is shutting down. We've got a 3rd degree AV block and inferior kind of injury pattern here. And so let's put this all together and see what we have. What do we have? We've got a 3rd degree AV block with sinus P waves marching through the rhythm. We've got a junctional bradycardic rhythm at 44 beats per minute, as well as ST depression throughout my inferior leads with ST elevation through my inferior leads with reciprocal depression in leads 1 and leads AVL. And so this is very concerning for an inferior ST segment elevation myocardial infarction with an occlusion of the right coronary artery. And that actually was confirmed in this patient when they went to the cath lab. Luckily for them, some of this AV node block did actually resolve once they did receive PCI therapy and stenting of the RCA, proximal RCA. And so, yeah, somewhat of a decent outcome for a tough situation. I hope this helps you guys understand the anatomy of the coronary arteries and seeing some things that aren't just ST changes with ischemia. So if you see inferior infarct with AV block or SA node function that declines, think RCA, 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 right? And this could be affecting some of the right ventricle, right? Understanding where the RCA goes. We know that the RV is very preload dependent, right? So we don't want to give them things that are going to decrease their preload, right? We want to resuscitate if these people are in profound cardiogenic shock, right? So really fun clinical stuff here, guys. If you have any questions, throw in the comments. If not, I will see you all tomorrow and have a great rest of your day. Happy studying. Take care.